everyone, and welcome to today's webinar. Today's webinar is titled In Silico Approach for Personalized Gait Modification to Decelerate Knee Osteoarthritis Progression. My name is Christopher Iverson and I work here at Anybody Technology. I will be the host of today's webinar and I'll be joined by my colleague Björn Ingelund, who is sitting right here next to me, and he will help us out during the Q&A session in the end. In today's webcast, we have an external speaker, who is Dr. Amir Esrafilian from the Department of Technical Physics at the University of Eastern Finland, KPO. And in this webinar, Dr. Esrafilian will explore personalized computational models and showcase how the in silico approach can help tailor gait modification to delay or decelerate knee osteoarthritis progression. And if you have not dived into the most recent paper on Dr. Esrafilian's work yet, then you can find it already. It's published in the Journal of Orthopedic Research and it's open access. The presentation will start in a few minutes or so, but just before we go ahead, I will give a general introduction to the Anybody modeling system for those of you who are unfamiliar with the software or musculoskeletal modeling and simulations in general. But first of all, I would like to draw your attention to the control panel, which appears on the right side of your screen. And you are very welcome to submit questions during the presentation via the questions panel. And we'll try to address all of the questions in the very end of this webinar. And in case we do not get to address all of the questions, we will do so by email within a reasonable time. So let's begin with having a look at what the Anybody modeling system actually is. Well, the Anybody modeling system is a software that allows you to do musculoskeletal modeling and simulations. As input, it takes motion data as kinematics and forces, and it calculates the internal body loads as joint moments, joint reaction forces, and muscle forces. And here in the bottom of the screen, you can see an actual screenshot from the software, so this can give you an idea of how it looks. And at the moment, Anybody is used in a wide variety of areas and applications. And a few examples of this is movement analysis, product optimization design, the field of sports optimization, ergonomics, orthopedics and rehabilitation, and assistive devices, which could be, for example, a special type of exoskeleton. And the typical workflow in Anybody could look something like this. So you provide some recorded motion data as input, together with some forces, and then you use the body models which you can build yourself or other users have built, which comes with the Anybody managed model repository. You can then combine it with some kind of environment model, which could, for example, be a lower extremity exoskeleton, as is the case in this example. And we can then use Anybody to combine all of these things and solve the muscle recruitment by running the inverse dynamics. And this gives us a simulation that looks something like this. We can then go ahead and output the internal body loads as muscle forces and joint moments, and we can use it for some kind of post-processing, which could be with, for example, a finite element tool. But many users also chooses to close this loop completely by doing some kind of design optimization and then run this simulation cycle multiple times. And this actually brings me to the end of the introduction, and I'll hand over the presenter role to Dr. Amir Esrafilian instead.
Hello, everyone. And thank you, Christopher, for the quick introduction. I hope that you can see my screen.
We do see your screen.
Okay, great. So I will then continue. Well, let's start with a brief introduction about myself. So I actually did my bachelor and master in mechanical engineering, and then in 2017, I joined the University of Eastern Finland to conduct my PhDs here at the group of biophysics of bone and cartilage. And currently, I'm a postdoc researcher with my research mostly focusing on the multi-scale modeling of the knee joint, with a focus on predicting the progression of knee osteoarthritis and providing tools for tailored rehabilitation and gait modification. And here is indeed where we are. So we are in Kuopio in Eastern Finland, and here on the left you can see our campus. If I go to lazy, okay. Here you can see our campus, and here is indeed my office where I sit, and I also indicated the rest of the campus here, and we are pretty close to the Kuopio University Hospital as well, which almost half of the research community is also the hospital, including clinicians, orthopedists, and surgeons that we collaborate. But to be honest, these days the campus looks like this, so we have a snowy, nice days. Let's start with looking at the knee, because the focus of the talk now would be the knee joint. So the knee is composed of two joints, tibiofemoral and patellofemoral joint. We have namely the bones, namely femur, tibia, and patella, which end of the joints are covered by articular cartilage, which provide a fascinating frictionless contact, almost frictionless. And we also have the menisci, which helps for a better distribution of forces, strain, and stresses over the cartilages. Then we have muscle tendon units that actively provide the joint movements, and we have then passive elements like ligaments, which restrain the joint and provide stability. But as the knee is very complex, it's reported that knee injuries are the second most frequent musculoskeletal diseases, with only knee osteoarthritis affecting about 400 million people across the globe. And according to WHO, osteoarthritis is defined as a long-term chronic joint disease, which is also very painful, and is primarily characterized by the deterioration of joint cartilage and the underlying bone. And osteoarthritis, of course, has different phenotypes, such as mechanical loading, metabolic, aging, inflammation, etc., which then it makes it important to take into consideration different factors affecting the progression of the disease. But one question here is that why we need modeling. And for instance, starting from some MRI here that we look, so we have some knee joints here, which is at the healthy condition with a pretty good articular cartilage, but then after some time we might end up to kind of severe osteoarthritis here, which then we have bone-to-bone contact, which is painful. There are some methods already based on, for instance, medical imaging, the machine learning methods, for instance, which can predict for us what would happen in this case, for instance, for the subjects in the near future. If he or she develops osteoarthritis. But these methods indeed cannot provide us with the mechanisms. That's what's the underlying mechanism of the progression of the disease. And they also cannot tell us what modifications we can do in order to decelerate or postpone the progression of the disease. Or in other hand, for instance, in other words, if for instance, we look at this MRI, we have some cracks here on the patella, which probably in 10 years or so, this subject would end up to a situation like this, around this lesion. But what or how we can then decelerate the progression of the disease to still maintain the joint in a relatively healthy condition. And then because the osteoarthritis has different phenotypes, also it's important to take into consideration the structure, function, and composition of the cartilage in order to then develop the models which enables us to predict the progression of the disease. So talking about the composition, let's first have a brief look at the composition of the cartilage. So essentially, cartilage is composed of mostly fluid. About 70 to 80% of the tissue is fluid, which is responsible for the rate and time dependency response of the tissue. Then we have the proteoglycans, which are negatively charged and are in charge of the compressive strength and swelling properties of the cartilage. We have the collagen network, which are responsible for the tensile strength. And then we have also cells, which then synthesize the tissue. But there are several studies suggesting that excessive loading, for instance, excessive tensile stress, can lead to distortion in the collagen network, or then excessive shear strain can lead to cell death, or then loss of proteoglycans within the tissue, which all of these together can reduce the load-bearing capacity. Then also they can increase the permeability, which then again lead to increased stress and strain in the tissue, and they can lead to rise in breakdown enzymes and also increasing inflammatory cytokines, increasing at the end catabolic response of the tissue. But on the other hand, also reduced loading can lead to cartilage softening, which when you have softer tissue, then it led to increased strains causing collagen damage, for instance. Again, increasing the breakdown enzymes and inflammatory cytokines, leading to an increase in catabolic response. Therefore, it's important to have a true knowledge of the knee joint mechanobiological environment and response in order to study the progression of knee osteoarthritis, which then in this case, computational modeling provides us with a powerful tool, which we can provide these estimates non-invasively. So looking at conventional computational models, so at the higher spatial scales, as Christopher explained to us, we usually use musculoskeletal modeling, which enables us to estimate kinematics, such as joint angles, kinetics, joint moments, muscle forces, and contact forces. But one limitation here is that these are the joint level mechanics, which often they are poorly correlated with the degradation response of the tissue, in our case, the cartilage. But then on the other hand, at the lower spatial scales, we use continuum mechanics-based modeling, such as finite methods, which then these models enables us to, of course, estimate kinematics and kinetics, but also we can go down to tissue or cell level mechanics, which then these have been shown to govern tissue degradation response. But the limitation here on this side is that typically these models are time consuming, and there we need certain level of joint mechanics in order to drive these models, for instance, joint contact force or primary knee kinematics as inputs to these models. And here is where the multi-scale modeling comes into play, which then is a combination of musculoskeletal models followed by a finite element model to then estimate tissue mechanics in different activities. So using this multi-scale modeling approach in this study that I will go through now, the aim was to analyze different gait modifications, and we know that gait modification is a common non-surgical approach to alter the load distribution at the joint, and the intention is to via unloading certain region of the joint and we decelerate the progression of mechanically induced knee osteoarthritis. However, the success rate of these gait modification approach is controversial, and the alteration in tissue level knee mechanics during these gait modifications are yet unexplored. So in this study, the aim was to first investigate the effect of different gait modifications on tissue level knee mechanics, and second, we aim to demonstrate if these computational models could assist in tailoring these gait modifications to favorably reduce the tissue mechanics. So in this study, we had 5 participants, all with medial tibiofemoral osteoarthritis with a KL grade 4. So we had 3 right knees and 2 left knees. We then collected 5 walking trials for each gait modification when the subject was in the motion analysis. So we collected the markers as well as ground reaction forces. And we evaluated 5 different insoles, lateral wedge insoles with 0, 5, and 10 degrees. And also we had different walking styles like with short walking, toe in, toe out, and wide stance walking. We then also collected MRIs to create personalized models. So we collected the lower limb MRI as well as a detailed knee MRI. So the lower limb MRI was a T1 rated and with a kind of a lower resolution that we used to create musculoskeletal models. And then the detailed knee MRI was a 3D test sequence with a higher resolution, which then we used to create the finite element models, which I will go through that in the following slides. As mentioned, we used the full lower limb MRIs, so we manually segmented the MRIs of these 5 subjects, as you see here. So we extracted the STL files for the bones, and then we used the 20 lower extremity model from the Anybody software, and then using the STL files of the bones from the model, then we morphed the model to the subject's bones, several steps, as shown here, and then we created the personalized musculoskeletal models of the subjects in which both the bones, the contact geometries, and also the insertion points of the muscles were obtained from morphing of these 2 geometries. Then continuing with the finite element models, we used the detailed knee MRI. We went again through the manual segmentation for the cartilages, and also here we segmented the bones, especially the regions with the total cartilage loss that we might have some contact with the underlying bone. Then using the segmented geometries and using hexahedral elements, we created the finite element models. We also had the ligaments in the model, which the insertion points were obtained from the MRIs of the subjects. And then in the FE models, bones were modeled as linear elastic because we were not interested specifically in the detailed tissue mechanics of the bones. So we just used a simpler material model to just make the analysis faster. But the cartilage and menisci were modeled using a fiber reinforced biobasic material model, which I will go through more details in the next slide. And the ligaments were nonlinear elastic springs with mechanical parameters obtained from the literature. And then using the kinematics and kinetics from the musculoskeletal analysis, then we run the stance phase of the gait using the FE models to then estimate the tissue mechanics. And the material model of the cartilage and menisci was a fibrin reinforced pro-viscoelastic material model in which the total stress in the material comes from three different components. One is a non-fibrillar matrix, the other one is a fibrillar matrix, and the third component is from the fluid within the tissue. And the non-fibrillar matrix indeed represent the proteoglycans within the tissue, and we use a hyperelastic Hookean material model. And the reason behind this was that this material model is shown to nicely follow the large distortions in the tissue. And then the fibrillar matrix, representative of collagen networks, were modeled using a strain-dependent viscoelastic material model. And we also incorporated the orientation of the collagen fibrils, both through the depth, which was an arcade shape, and also on the superficial zone, based on the literature, were different for patella, femur, menisci, and then the tibia. And the fluids, we had a depth-dependent and also strain-dependent permeability, and then fluid content in both the cartilage and menisci. Then the inputs to the finite model that were calculated from the musculoskeletal models. So here I'm showing a schematic of the MS model. So in general, we have the bones, we have some muscles around each joint. So here the focus is the knee joint. And then we have the equivalent finite model with the kind of identical coordinate system. So we match the origins using the STL files. And then also we defined a coordinate system for the patella, or let's say a reference point for the patella, which then the inputs to the FE models were applied to these reference points, which were identical to the coordinate system origin of the musculoskeletal model. So then from the musculoskeletal analysis, using the inverse kinematics, we estimated the knee flexion angle, which was one of the inputs to the FE model, and also then just plotting the free body diagram and calculating the net force and moments in the femur. We obtained the net force at the center of the femur here relative to the tibia, coming from the gravity, inertia, muscles, and also because here we have the joints and hip joints, also the contact force from the hip joint. And there were some plots like this as a function of time during the stance phase of the walking gait. And this combination were then applied on the femoral reference point. Likewise for the patella, the exception that here we drove all the degrees of freedom for the patella using forces and moments with no flexion angle, because we cannot get it with the acceptable accuracy from motion analysis. So inputs to the patella were 3 forces and 3 moments from the gravity, again inertia, and quadricep muscles applied to the patellofemoral reference point. And in all the FE models, we just fixed the bottom of the tibia, and all the inputs were relative. For instance, femur relative to the tibia, or patella relative to the tibia. The results of the musculoskeletal analysis are reported in a separate paper. So now I won't go through the details of the musculoskeletal results, and for those who are interested, you can scan this code or just click on this link and read more about the results from the musculoskeletal analysis. In this paper also, the personalized or subject-specific musculoskeletal model results are also compared against the conventional method, which we use the linearly scaling method to scale the model based on, for instance, subject height and subject weight. But going through some of the results from the finite element analysis, here I'm plotting the knee kinematics, which are secondary knee kinematics indeed. On top, it's anteroposterior translations. Then we have mediolateral translation, varus valgus angle, and internal external rotations for all the 5 participants of the study. No need to go through all the details of this plot. So what I wanted to show here was that what we observed was that effect of gait modification on knee kinematics varied across participants. For instance, here in participant 1, 3, and 4, we observe more differences between each of these modifications compared to, for instance, participant 2 or participant 5, which the variations were considerably lower. And in line with the literature, also what we observed was that these lateral wedge insoles, although they are still used considerably by clinicians, so we didn't observe that much of difference when using lateral wedge insoles compared to, for instance, shod walking, and also compared to the rest of the modifications. So here the lateral wedge insoles are the color lines and the solid color lines. So what we observed from the kinematics was that the gait modifications showed the potential to effectively alter the knee kinematics. And looking at the kinetics, or more specifically the knee contact force for these 5 participants. So on top, we have the total tibiofemoral contact force, then we have the medial to total ratio of the contact force, and then on the bottom, we have the amount of the force going through the subchondral bone. And by this, I mean the regions that we had total cartilage loss, that there were contact with the underlying bone. So this is indeed the amount of the force going through that region compared to the whole contact force. And likewise, the kinematics, what we observed here was that the effect of gait modification was also variable between the participants, like participant 1, 3, and 4 compared to participants 2 and 5. And likewise, again, the lateral wedge insoles caused minimal alteration in the knee kinetics. And we also observed that these gait modifications could also affect the amount of the force going through the subchondral bone, which, due to the reason that we have nerves there, it seems that using these gait modifications might also help to alter the knee pain or decrease the knee pain due to decreasing the amount of the force or contact, let's say, to these regions with the total cartilage loss. So the take-home message here is that was that the potential of gait modifications to alter both knee kinematics and kinetics. And also one question here might be that maybe the model can also assist in tailoring these gait modifications to decrease the knee pain. And this is indeed one thing that we are looking into in our future research. And then going through the tissue mechanics, here I'm showing the distribution of tissue mechanics, specifically collagen fibril strain, which these are at the time point of the peak of joint contact force for all the 5 subjects. On top, it is the collagen fibril strain when the subjects walk barefoot. Then we have the shod walking, we have the best case scenario and worst case scenario, which then the best case scenario is the modification, which ended up with the minimum collagen fibril strain during the stand phase of the gait. And the worst case scenario is the modification that gave us the maximum collagen fibril strain during walking. So what we observed was that some of the gait modifications could significantly, or let's say considerably, increase the amount of tissue mechanics, which then it might indicate that gait modifications even have the potential to negatively affect the health of the tissue, or in this case cartilage. The other thing was that in some cases the best case scenario had only minor changes compared to shod or barefoot walking, but then we also had cases that we observed considerable decrease in the tissue mechanics compared to shod walking or barefoot walking. And one other interesting finding was that it matters whether we use joint level mechanics or tissue level mechanics to obtain the best or worst case scenario for the gait modification. For example, here on subject 5, if we use just the joint level mechanics, so the toe in gait modification, as shown here, showed that it could minimize the joint total contact force, as well as it could minimize the medial to total ratio of the joint contact force, which means it would be the best case gait modification to minimize the contact force at the tibial cartilage. But when we looked at the tissue mechanics, here collagen fibril strain, this was indeed the worst case scenario, which then led to the maximum tissue mechanics on the tibial cartilage. And one reason when looking at the internal and external rotation, this toe-in caused the maximum value for the internal rotation of the femur, which then leads to external rotation of the posterior femur, causing more stress and strain on this region of the tibial cartilage. So to conclude, what we saw was that the optimum gait modification varied across the participants. So it seems essential to use personalized methods and not the one-size-fits-all approach to provide the best case gait modification for each subject. And also the optimum gait modification could differ depending on whether we use joint or then tissue level mechanics to minimize that quantity and provide the best case modification. And overall, we also showcased the potential of the computational modeling to assist in choosing the optimal gait modification, which then may lead to minimize the tissue mechanics governing the degradation response, leading to decelerating or postponing the progression of osteoarthritis. And the other thing was that it seems that these models also hold the potential to decrease pain as well by changing the amount of the load going, for instance, to the regions which we have contacts with subchondral bone, or with the regions that we have nerves there, which then might increase or decrease the amount of the pain. With that, I also would like to briefly walk through some of our current as well as our future research as a continuation of this research that I presented. So in one of our research that the preprint is also out. If you want to check more details, you can scan the code here, or also here is the DOI of this preprint. So we developed a tool which enables the automated knee modeling, because creating the models, both musculoskeletal and finite models, just creating the models, let's say the running aside, might take several days or weeks. And we try to make it fast, bring it down to several minutes. And this tool enables us to create the models in about less than 10 minutes. And the tool is based on auto segmentation. So we used unit, 3D and 2D units, and we trained the network using knee MRIs from different sequences, T2 or dead space sequence and proton density and T1 sequences, to train the network, which enables us to automatically segment bones, cartilage, menisci, and major knee ligaments. And then, because we have bone and cartilage, then the tool also creates a cartilage thickness map, which we plan to use this information, well, first as a kind of assistive tool that it can inform us how much is the thickness of the cartilage, and it can be used as a diagnosis tool. Or then we plan to use it to estimate the strain map before and after some certain activities, which then this also can be used to validate the models, or then to calibrate the material parameters or other parameters of the model. Then the tool also creates the musculoskeletal model for us based on the MRIs and from the auto segmented geometries. And the model here, it has a 12 tibiofemoral knee joints, tibiofemoral and patellofemoral joint, and we have also ligaments with the insertions again from the segmentation. The model also is capable of including the menisci, and here we have an elastic foundation contact, which is equivalent to the discrete element methods for those of you who use that method. And it enables us to rapidly estimate the contact pressure compared to finite models that take several hours. So here the model takes about 5 to 10 minutes to run. And then the tool also create a finite model with a fiber reinforced polyscholastic material model incorporated, which, as I explained, in the material model, we had the depth dependent water, proteoglycan, and collagen content. And we developed the tool to use two methods to create the models, template based method and auto meshing method. And the idea was to kind of always, and in 100% case, we could take the model if one of the other method fails. And we also develop an algorithm to extract the ligament insertion points from the MRIs to incorporate them into the model. And our next studies, the aim is to provide some tools which also enables us for the out of lab data collection and running these models. So what we're focusing on is to use 2D videos to replace it with the motion analysis system, which are expensive, which needs special expertise. So here the aim is to just use 2D videos 1 or 2 cameras to then, using this method, it estimates the kinematics and kinetics for us. And also we plan to develop some surrogate models or then AI methods to accelerate the analysis, which then provides us the tissue mechanics, including degradation of the tissue in nearly less than seconds or several seconds compared to several hours, which the finite models takes to run. And also in a project called MatCoA, we also try to investigate the correlations of the pain and provide mathematical models for the pain, specifically at the knee joints. And the aim is also to integrate this pain mathematical model into our models to provide estimates both for tissue mechanics as well as the knee pain. And the ultimate aim is to provide clinically viable in silico tools for personalized rehabilitation and gait modification. And the way that it's supposed to work is that you use 1 or 2 cameras like cell phones, then you record the motion, and it provides an estimate that what would be then the tissue degradation response during different rehabilitations or activities. And based on that, you can select one of the activities, or then we can do the retraining, etc. With that, I would like to thank all of you for your attention and for your time. Also, I would like to thank all the collaborators and supervisors in this work, specifically Professor Korhonen from University of Eastern Finland, Professor Anderson from Aalborg University, and also Professor Jim Woodburn from Griffith University. And for those of you who are interested, so we currently have this MatCoA project going on. Here I put the link. You can have a look or just Google it and read about this project and what we plan to do as the next step of the research. And that was the presentation, so I will give it back the stage to Christopher. Thank you.
If you want to know more about Anybody Technology, then you can go and check out our website, anybodytech.com, which is where you can find different events, special dates, and also previous webcasts similar to this one. And there's also a full publication list where we try to maintain a list of all of the studies which has been published using Anybody. And there is like a great filter on this list, so you can go there and select your field of work, and then it will give you the results of what have been going on in orthopedics, for example, or with the knee already. So it's really a great place to get inspired with what has already been done. You can also check out our community website, which is called anyscript.org. And this is really a website for people using Anybody already, and you can go and find multiple online resources as our wiki page, several blog posts, and links to our repository sites. It's also here our forum is located, so you can go and ask questions and get help from fellow Anybody users. Then I would also like to announce that there's the annual meeting of the Danish Society of Biomechanics, and it's coming up this Friday, actually, the 24th of November in Aalborg, Denmark. And Anybody Technology will be there. So if you have any questions and you happen to be at this event, then please stop by our booth and say hi, and we can discuss how we can use musculoskeletal modeling and simulation in your work. And last but not least, if you have any questions or you just want to meet up or get a trial of our software, then please feel free to send us an email at sales@anybodytech.com. And if you have any questions to this webcast or any of the previous ones, then please feel free to send me an email directly at ki@anybodytech.com or reach out to me through LinkedIn. And with that, I would like to thank you for your attention this far, and then it's time to have some questions. So, Björn, you have had time to look at the questions, so could you please read out the first one?
Yes, so hi Amir, and thank you for the presentation. So the first question from the attendees is about the steps you took in order to create your subject-specific Anybody models. So you did use the morphing technique to morph the bones to match the ones you had obtained from the MRIs. But the question is about, do you think that that is a sufficient method compared to taking a generalized linearly scaled model and then implementing a more detailed knee model?
Well, good question always about the personalized versus those conventional linearly scaled models. Well, with that, I think we have also Professor Anderson online here. I think he can, if he's online, still probably the best person that can answer that. This is Professor Anderson, but if he's not online, well, yeah, there are also other methods which then also help us to calibrate the muscle tendon parameters like muscle strength. But we have seen previously in other papers, one of them is published in 2015 there, and there they also use these personalized versus linear scale models to then estimate in vivo joint contact force. And we have already seen that these personalized models, just based on morphing of the bones, just accounting for geometries, contact geometries, it significantly increased the accuracy of the estimated contact force. But of course, that's for few subjects, few activities. Still, in general case, I think it's still difficult to say if for in all the cases this approach can increase the accuracy. But what we have seen is that at least for those subjects, it increased the accuracy of estimating the contact force at the knee. In addition to that, it seems to necessary to also account for personalized muscle parameters, which was not included in this study. I hope I could answer that question.
Yeah, I think you did, and I think it also relates to the good slide you had on your next step with the automated knee pipeline. You showed a very nice picture of what a more detailed knee model actually looks like. So I think you are also on the path to actually doing some of the next steps of doing more personal specific modelings. Thank you very much.
Yes, there also we compared this more complex knee model with 12 degrees of freedom compared to 1 degree of freedom knee joint. What we saw there was that if we personalized, even with the 1 degree of freedom model, if we personalize the joint geometries, which is a function of like contact, if we have the bones there, we just update the secondary knee kinematics based on the even the passive flexion test. That also increased the accuracy of estimating contact force comparable to this 12 degree of freedom model. But if you are interested to also estimate more accurately the secondary kinematics, that it seems more important to have this more complex knee joint model, which in anybody is the force-driven kinematics model. We have this equivalent 12 degree of freedom model. If any of the listeners are interested, they can go and check also that study, which then these models are compared.
Thank you very much.
And I think also interesting that the winner of this Grand Challenge dataset, if I recall correctly, was one of the studies that anybody model was used there. That's indeed the study that I'm talking about. So if anybody interested can go and have a look.
Thank you very much. And yeah, if you want to check out any of these studies, then please do go to the publication list I mentioned already. I will just assign the next question to you. So first of all, we have one attendee who says, excellent work, Amir, and he would like you to elaborate a bit on how accurate your estimated knee kinematics and loads are. So in other words, is the workflow accurate enough for your conclusions based on differences of a few degrees between different gait modification strategies?
Well, that's also a good question. Thank you. We have done many studies to validate these pipelines. In another study by a colleague of mine, there we looked at the follow-up data as well. So we used the musculoskeletal and finite pipeline to estimate this degradation and also to estimate where is the peak of these tissue mechanics. And then we compared that with the regions with degradation from the MRI, quantitative MRI, T2 and T1 row, which then shows degradation in collagen network, or at least it suggested that they show degradation in collagen network and proteoglycan loss. And we observed pretty nice match between these two. In some other studies, we then compared the contact force from the musculoskeletal model as well as FE models. But again, in general, for all the subjects, again, it's, I think, difficult to say if these are accurate for all the subjects, considering that different diseases like osteoarthritis, we can have co-contraction of the muscles. We have certain amount of consideration for these effects into our models, but they're continuously validating more and more these approaches. Yes.
Thank you very much. So, yeah, Björn, can you read out the next one?
Yeah, so the next question is maybe a little specific to German work, you can say. So we have an attendee that is asking about an occupational disease that they see a lot in Germany called osteoarthritis, and it is assumed to be something that exists after prolonged kneeling and squatting postures. So postures that involve knee angles above 130 degrees. And he is wondering if you did simulations of such postures, and if you can say anything about if the model is valid for simulations with such a high knee angle.
Well, yes, we did. We have done that kind of study, not specifically. I'm not familiar with the disease, but in one of the studies which were recently published in 2022, so there we investigated the effects of different rehabilitations, which there we also had some exercises with joint angles to more than 100, 120, 30. And then there we used a musculoskeletal model which were developed more specifically for the activities with higher knee and hip flexions, because there is a challenge, yes. Well, there we also observed that, again, the validation of the model is a question. So there we compared it. There are some data sets that they did different activities like stair ascent and descent. This is the CAMS knee data set. There we used the estimated joint contact force. We compared them against that data set, but of course that's not too many activities and not, again, too many subjects. They are with instrumented knee implants. But yep, we used the model there as well. So there again, we observed that the effect that we saw, the tissue mechanics, again, varied between the subjects. But validity, again, as explained before, still I think it is very strong to say if the models are valid or not. But we have some evidences, and that's what I can say.
Yeah, for sure it is. But I think that was a very good answer. Thank you for that, Amir.
Thank you.
Thank you very much. Then we have a few attendees asking about how we can get the slides, and I can say that I will process this recording along with Amir's presentation, and I'll make it available on our website in, I believe, before the end of this week. So it should be out there shortly. And then I'll just assign the next question to you. So we have one attendee who would like to thank you for a very interesting presentation, and she wanted to ask, once you predict the outputs with the FE model, what parameters do you re-enter as input into the musculoskeletal model to close the optimization loop?
Mm-hmm. Well, because the finite modeling is pretty time consuming, we still haven't used that loop. As I mentioned, it's about like 30 hours to run just one cycle of FE model, and if you want to make a loop for optimization, it might take months and years. But again, I think it depends on the question. So is it to, for instance, optimize the effect of muscle strength on tissue mechanics? Is it the question about how, for instance, stress or strains are affected by some optimization routine? I think it's totally dependent on the question. But in general, what we usually use from the output of the FE models are usually maximum shear strains, collagen network strains, which previous studies have shown that these are kind of shown evidences that they are correlated with the collagen network damage, cell death, and loss of proteoglycans. But more than that, I think it's highly dependent on the research question.
Thank you very much. So let's just have a look. Do you have anything more, Björn?
No, I think we've covered what we can today.
Perfect. I think we reached the end of the questions then. So I would just like to thank you for a great presentation once again. And thank you for all of the attendees who took the time to listen in. So I hope to see you again for another webcast in the future. And with that, I would just like to wish you a great day, and thank you for this session.
Thank you. Have a great day.